also cover some things that aren't sexually transmitted. But I just thought it's funny when I made this, the slide last year, Pokemon was really big, you know, the game and stuff. All right, and how many of y'all did this when you opened my presentation today? So, there's not 243, there are 150 something. But a lot of them are pictures. If you went through them, there's a lot of pictures. Because I feel with venereal diseases, they're all going to come in with the same complaint. They're having some type of discharge, you know, or this and that. This lesion has a sore. So, I think seeing it and, you know, remembering it on your slide along with the other hundreds of slides, it might stick in your brain, okay? General. So for this one, and I think for any pre-med lecture, I think that if you can recognize a disease, one of these common STDs, recognize it, figure out what you need to do to diagnose it, and then how to treat it, and then also know it backwards too. So if you were to get you order a smear and you see this on a smear, what could it be? So think backwards as well as forward, okay? So this is just an overall slide about sexually transmitted diseases. The most common ones are chlamydia, gonorrhea, and syphilis. So syphilis has made a big resurgence in the last few years. I think on campus last year, we actually diagnosed, I want to say, maybe 2 or 3 cases of syphilis. So, you know, usually after 1940s, which is where I think is weird, when penicillin was invented, it eradicated it. But then eventually people decided they're going to become more promiscuous, and it's on the rise. So, this is just a little statistics I took off of the CDC website to tell you approximately how many millions of cases of chlamydia that were reported in 2016. So 1.6 million. And they estimate actually around 2.9 million, those are reported and unreported cases of chlamydia this last year. Gonorrhea is a little bit second place, and then primary and secondary syphilis is in third. And then, oh yeah, there was a rise in syphilis, which I just talked about. Why is it always me? Okay. So these are the ones that we're going to discuss, we'll go over today, is chlamydia, gonorrhea, trichomonas, and syphilis. So chlamydia. Now, this one is one you're going to see a lot, but also you see with chlamydia is usually gonorrhea. They kind of go together like peanut butter and jelly. But you'll see it every time you see someone with gonorrhea, they usually have chlamydia and vice versa. So usually you see chlamydia in young adults, 15 to 24 years old. Okay, so this is usually whether or not a board question or an exam question, but you can also find chlamydia in older women, those who have multiple sex partners or new partners. Because a lot of times, as you'll see in studies, I think there's one on HIV, as we get older, we think, oh, it's not going to happen to us, so then they get more lax about protection. So there's actually there's a study about nursing home patients, the high amount of HIV in those persons, which I thought was kind of interesting. Because they're all in a nursing home together and they think, oh, we're all safe. They're not. Okay, so chlamydia is transmitted by mucosal infection, either during vaginal, oral, or anal sex, and it's highest among African Americans. So with that said, you know, according to the CDC, they recommend that you screen any sexually active woman under the age of 25, or those who are older who have, you know, high sexual promiscuity, or someone in the workplace that might be their job. So you might want to check them. The incubation period for chlamydia is usually 1 to 3 weeks, and it's just a list of complications that you can have with untreated or even treated chlamydia, which is PID, which is pelvic inflammatory disease or disorder, ectopic pregnancies, and infertility. And this is just a map I thought was kind of interesting from the CDC. looking at the reported cases by state. Look at the blue state of Oklahoma. Look at that. We're almost to the top of the top as worst as cases of chlamydia. So it's 508 to 560 per 100,000 people. That's a lot of sharing.
Alaska's the worst.
Alaska is the worst. You know, maybe the highest in teen pregnancies, and that's very high now. Diabetes, and then lowest pay for teachers.
And lowest education. So
That's right.
It all makes sense.
But we're the highest, one of the highest in chlamydia. So, yay us. So, the chlamydia family, there are 3 species within this family that cause disease in humans. The first one is the Chlamydia trachomatis. And this is the one that actually causes usually the urogenital infections. Then you have C. pneumonia. Do you remember that from foam? Causes pneumonia, bronchitis, pharyngitis. And then this last one I thought was kind of interesting. It causes parrot fever. I've never heard of it. But don't worry about those 2. It's mainly the top one that we're going to be discussing today. And within Chlamydia trachomatis, there are 18 serotypes, and there's a list of them right there. The ones that what I want you guys to know is to differentiate between those 3 right there. What causes what disease? Okay, so a trachoma is actually an irritation of the lining of your eyelid. So that gets really rough, and then it will start scratching on the cornea, and then that can lead to an entropion, and sometimes it can eventually lead to blindness. So that's usually the serotype A, B, and C. And then D through K is what causes the STDs. And then L1, L2, and L3 are something that causes the lymphogranuloma venereum, which we'll talk about later. And then this one, I put this in here because I didn't know where else to put it. So with all these diseases, I want you to look, what would it look like under a microscope? Okay? So that's how you'll, not that you guys are going to be master microscopists. I know. But so this is a gram-negative, and this will also help you determine on what antibiotic to use, by either gram-negative, gram-positive. So this is a gram-negative bacteria. Okay, so these are the infections, again, with chlamydia. There's a lot of repeat in these, so you'll see that. Chlamydia can cause non-gonococcal urethritis and epididymitis in men. It can cause cervicitis, urethritis, and then later on PID in women, and also what's something called Reiter syndrome, which that's what we were taught in PA school is Reiter syndrome. Now they call it reactive arthritis. And then you can also have transmission from mother to baby, and that's why, have you ever seen babies when they're first born have all that goopy gunk on their eyeballs, is to help protect them, because you can transmit it transvaginally when they're coming out with the baby. So, and then both chlamydia and gonorrhea infections cause a higher risk of acquiring HIV, just because you have that change in the mucosal lining and inflammation that causes the HIV serotype to be able to attach on the cells. Okay, so transmission, like I said, is either genital or, in this terms when I was studying it, is vertical, so basically going up to the baby. It's highly contagious, and you'll see that. So basically they're saying one time with an affected partner, you have a greater than 50% chance of catching it. So 60 to 70% of infants can get it through passage of the canal, the birthing canal. Because what happens is a lot you'll see is most of these patients with chlamydia, they're asymptomatic. Most of the girls and men don't know that they have it. And so when they don't know they have it, they like to have unsafe sex, which I find it interesting working over here at the clinic, how many young adults don't use protection. You know, and I remember, I thought we were always like, you know, giving speeches after speeches about using protection. And I think through the years it's fallen off because of, one, money. You don't see ads anymore for venereal diseases or STDs, right? And so the word's not getting out there. And I think people, or I think young adults who don't get that talk, which I think, do they get the talk in 4th grade, 5th grade? 5th grade. But that's a long time from 5th grade and a freshman in college, that they may not get it again. And so,
Get it again in junior high, maybe?
Yeah,
we got it in
9th grade because I had to
Fifth
give
grade's
it.
developed.
and so, and now too, I think a lot of times if they're uneducated about protection, a lot of young women think that they're on the pill, so that protects them from everything. You know, well, it protects you from getting pregnant, not always, 98% of the time, but there's that 2% you can still get pregnant. So I think that is why I feel like there's a rise in it. And also reinfection is common because, again, they don't know the partner's positive with chlamydia, and so, or a new partner or anything like that, because I'm sure they don't ask them that the first time they decide to have their course. So, signs and symptoms, and this is in women. 80% are asymptomatic. Like I said, may develop cervicitis, and so you'll get this discharge from the cervix, and it's usually like a clear to thick yellow. Now, sometimes it's hard to tell the difference between an abnormal discharge and normal discharge, because it is normal to have discharge from women. You can notice it more around the time you're ovulating, that you may have more discharge, so sometimes it's not always abnormal. So when you have someone come in complaining about vaginal discharge, make sure you ask them when was their last period and when do they notice this discharge, because like I said, a lot of times you may think it's abnormal and it's not, so just let them know that. You can also get some intermittent bleeding, so bleeding between your periods when you have chlamydia. And then you can also develop urethritis. So this is the dysuropyuria. So you might on a UA see pus in there, but not very much bacteria, like not many WBCs. And then the abdominal pain can be more from if they develop PID, same with the fever. So this is a normal cervix, which you guys will be seeing next week, maybe. So, and I think this is postpartum, because usually they're going to be more oval shaped, more of a thin slit, and that redness around the opening of the cervical os, that is actually what's called the transformation zone. So you'll notice whenever you do a thin prep or a prep or a thin prep with the swab things. Still got the nice little. I'm sure all the women know what this little container is, right? This is the thin prep. So with it, when you go to do a pelvic exam, your nurse will be there to help you along, but she'll usually hand you several things. So the first one is the brush. I don't know what the actual term is, I just call it a brush. But the way it's shaped, that's supposed to go into the os, and enough to get to that transformation zone. So when you do it, you twist it. I think the instructions say 5 times to the right. But a lot of times this is real soft, and so it doesn't get the cells around the os very well. So a lot of times they may hand you this brush, which is, it's still soft, but it's a little bit more firm. And so, but this one will make them bleed more. So I don't know if you all have ever noticed after you've had a pap smear that you may bleed a little bit or spot. They may have used this brush because it definitely gets the cells better. And then usually this one they'll use to give you like a swab. If you have discharge, they can take that off and send it for culture, or they may put it on a slide and look under the microscope. My OB still does that. She still looks under the slides for any discharge rather than sending it off. I'm not very good at looking under a microscope, but that's that. And then usually your nurse will take that from you, and then I think they take it, and when you do it, and if you have to do it by yourself, you would take it and you would push it, mash it down to the bottom to get all those cells off the brush when you do it. And I just swirl it and swirl it, and I look to make sure, because it'll have a solvent in there, this one doesn't, but mash it around so you get all the cells off of the brush. Okay. And then a lot of times if you will get a report back, and if it says no endocervical or transformation cells noted, that means you didn't go deep enough or you didn't do enough swipes to get enough cells. So then what you'll have to do is you'll have to bring that patient back and repeat their pap smear. Okay. And so this is chlamydia. See the difference? Yeah. You can't even see the os, right? And so this is what you'll look at if you guys have no one's done a pelvic exam. Have anybody done a Good Shepherd?
Yeah, once a Good Shepherd and before two.
Okay, good. So, this is what you'll be kind of looking at. So the top, that silver part is your speculum, and then the sides are the vaginal folds. So what happens a lot of time in big women is those folds will collapse down and you won't be able to see anything. And so sometimes it gets, as a student, I remember getting really nervous because I can't see anything but vaginal folds, and I don't see the one-eyed monster, and I was like, I'm never going to find it. So what I tell my students is, when you're doing your exam and you don't see anything, don't freak out. Just pull the speculum back out and then reinsert and go down. So you want to aim, when your patient's on the table, you want to aim towards the table, okay? And then you put towards the table and you flick up. And most of the times, that cervix will pop up for you. Or if it's up top, then you may have to just lift it a little higher when you're pulling up, and it'll flop down for you. Okay, so this is symptoms in men. So again, 50%, greater than 50% of men are asymptomatic. They can develop as well a urethritis. So this is the non-gonococcal urethritis. And they'll get a clear or yellow discharge. And then sometimes they may call and say, I notice I've got this thin, crusty, residue on the top of my penis. And so it's just that dried discharge. They may have dysuria. Now, if they're men who have sex with men, they may develop a proctitis. So, because of anal intercourse, and that's where their symptom will be. But the majority of the time, it's going to be out of the urethra that they have symptoms. They can develop urinary frequency, dysuria, and the incubation period is about 7 to 21 days. And in the men, the complications aren't as common. But for them, like I said, they can develop epididymitis or reactive arthritis. But they don't have it as often as in women. Okay, so this is discharge. This is the only good picture I could find. And I was thinking, I sure hope no one would ever scan my computer just for and see what I was searching for. I was like, oh my God, I'm so embarrassed if someone ever look at my search history. So you can see there's a little bit of thin, clear discharge there. It's not as copious as you'll see when we do pictures here in a minute of gonorrhea or trichomonas. So on physical exam, this is how you diagnose them. You're going to do physical exam, take a history. I forgot to put history on this side, but someone comes in complaining of discharge, you're going to take a thorough sexual history, right? When was the last intercourse? With whom was it? Did you use protection? Have you ever had an STI before? Have you ever had symptoms like this before? So those are all important questions that you'll want to ask them. Then you ask them their normal symptoms. What does the discharge look like? Does it have a smell or an odor? Things like that. So we already said that for the men. So you can do what's called milking of the penis to get discharge out. Sometimes in men it may not be there, so you may have to milk the penis to get some of the discharge out. And then you can also do lab testing. So back in the day, the primary diagnosis was doing culture of it and putting under, send it off, or you can look it under a microscope. But nowadays, you have what's called NAATs, nucleic acid amplification tests, or then the PCR is what we use over at the clinic. So that's a polymerase chain reaction. So they basically amplify the nucleic acid tests because these tests look at genetic material. So they don't actually look at antibodies like some of the other tests do. These nucleic acid tests usually look for genetics, so some type of DNA. So DNA is really small, so they use things to amplify it, and so that's what the PCR does. And you can actually do urine PCRs to check for chlamydia and gonorrhea, both. Or you could do, urine they say mainly for men, but in the clinic we do for both. But if you can, a vaginal swab is preferred in a woman if you can get discharged that way. And then culture. And treatment. Are you having an STD treatment lecture by Dr. Latassi? Did she do one? Okay. Then your treatment question will come from my side. Okay. So, what was I telling earlier? I was telling Kristen. When I was in PA school, STDs were my Achilles heel. treatment, the treatment was. And so I was like, it's funny, here I am teaching STDs. So if you can memorize these, they're usually the same for both gonorrhea and chlamydia. One of them has Rocephin. See, I can't even remember it now unless I get the slide. But remember, azithromycin for chlamydia, 1 gram in a single dose. The only time you wouldn't is if someone has some heart arrhythmia. Or if they have an allergy, you can use doxycycline. But remember, what's the side effect of doxycycline? The major one? So always run these medications. And there's some alternate choices as well. But most of the time it's going to be azithromycin 1 gram in a single dose. So it's usually easily treated, right? 1 single dose is much easier than these other ones down here. We have 500 4 times a day for 7 days. Most likely they'll take the 1 gram. These are just some special points. If a person, let's say a student or a person comes into your practice and says, my boyfriend just found out he had chlamydia or blah, blah, blah. They've been exposed, treat it, okay? And if you think it is, treat it. And then you want to make sure that they tell their partners and their partners get treated as well. Because what happens, they'll get reinfected, okay? And then you want to tell them they need to abstain from sex for 7 days. So after that 1 single dose, they need to wait 7 days before they can have sex again, okay? And then, like I said earlier, 40% of women and 20% of men who have chlamydia also have gonorrhea. And you really feel bad when if it's a young girl that comes in and they find out they have chlamydia and they don't know how long they've had it, and they may have had a new partner that they think, oh no, he's been tested, he's fine, and then they have to start thinking about who the partners have had before, and then who to tell and who to yell at before. That just happened last year when I saw a girl. I felt horrible. And then you can do what's called a test of cure. So usually 3 weeks after they finish their treatment, you can retest them to make sure that they've cleared the infection. So usually it's unnecessary, but you can retest 3 months after, because like I said, it's a high risk of reinfection in both men and women. Yes?
For their partners, would you write the prescription, or do they need to go see someone?
No, I always tell them to make them to go see their primary care. Or if they're obviously a student on clinic, I would just tell them to come there. And it comes in waves. You'll see, and you'll know who patient X is on campus. Because patient X comes in, then you see a drove of girls come in. And you're like, oh my God. And then you look differently at the person who came in the first time, who patient X is. And you're like, I know what you did last summer. Okay. Yes?
For the 7 days that they're abstaining, is that from, like, if they do a 7-day treatment, is it from their last day of treatment?
Yes.
Okay.
Mm-hmm. Okay, and then sexually active men who have sex with men, so MSM is usually the abbreviation they use, should be screened annually for urethral and rectal infections. And then, so the same men who have sex with men who have HIV, you want to screen them even more often. You do it every 3 months. And this is more, I got a lot of this from the CDC, but HIV patients, when they come in for the first time in their clinic, if you end up working in an HIV clinic, you want to make sure you screen them at their first visit and then annually thereafter. Now again, you can do it more often if they are more sexually promiscuous. Sex partners should be evaluated, treated if they've had sexual contact with the patient in the last 60 days. And then both chlamydia and gonorrhea are reportable by law. So if you find a positive, you have to report it to the State Department. Okay, and then earlier, a complication like we talked about, something called PID. Basically, the infection ascends to the fallopian tubes and the ovaries, and so a lot of times people get scarring. So then women will have this chronic abdominal pain from the scarring. And then as long as it continues to be untreated, they still don't know that they have chlamydia, they can increase the risk of infertility because of all the scarring in the fallopian tubes and the ovaries. And then they can develop something called Fitzhugh-Curtis syndrome. Did y'all talk about that in GI? briefly. So it's basically a perihepatitis. So you get inflammation of the capsule of the liver, and you can have fever, you can have right upper quadrant pain, some nausea, vomiting, and some elevated LFTs. And again, with this, with women, you can also have, men and women, you can have the reactive arthritis. Which I'm going to talk about here in a second. So reactive arthritis, or Reiter syndrome. This is known by I remember learning this in PA school. It's polyarthritis, urethritis, and conjunctivitis. So if you get somebody who comes in and complains of a discharge, and they also have all these symptoms, you have to think of reactive arthritis. And then, so if you think, oh, they come in with just swollen joints all over their hands, and you do an RF panel, which, have you guys had rheumatology? You did, okay. Then that would be seronegative, right? And then, but you could do some genotyping, and it'll come up with an HLA-B27. Who remembers what that's also associated with? It's a board question. Good job. So this one you just remember, they can't see, they can't pee, and they can't climb a tree. So that's reactive arthritis. So this is how I learned this. If you can tell, this is how I studied in PA school. I make up things so I can remember them. Which I don't remember you, and I'm sure I told some people, when we were learning pulmonology and having to remember what it looks like on an x-ray, bronchiectasis, you know, they have all the little pinholes all through their lungs. We used to sing, shot through the heart, bronchiectasis. And I remember that now, 10 years later. Okay. And then this was a subtype that causes disease in humans. It's L1, L2, and L3, and it causes lymphogranuloma venerum. And these people, they get these small, usually they're asymptomatic lesions, but then what happens is these lesions can get bigger, get more ulcerated, and then they get lymphadenopathy. And so usually this lymphadenopathy is bilateral. It's usually suppurative. It's very painful. And then when these little small lesions heal, they can also develop sinus tracts. So they'll keep reinfecting and have little tunnels. And you guys will learn that like in derm and something else with sinus tracts are underneath the armpits. But these people, it's the main big inguinal lymph nodes, right? Because of the drainage right by there. So severe proctitis, if they required it by anal sex. How do you diagnose it? Culture, you can do antibody detections or the NAATs. Treatment is with doxycycline for 21 days. That doesn't look painful. And so the one on the left with the vagina, and that's, I think, their Bartholin's or their Skene's glands that get swollen. Or it could be a lymph chain right there. That's another picture. Gonorrhea. So, I don't know what it is, with this clicker. So gonorrhea is caused by Neisseria gonorrhea, and it is a gram-negative diplococci. So all these bolded ones, I want you guys to start to remember which is associated with, okay? It's the second most common reported STD. Incubation period varies from 1 to 14 days, but most of these patients, once they've been exposed, they're usually symptomatic within 2 to 5 days, okay? Again, it's transmitted through the mucosa, either an open tissue, scratch, minor opening in the mucosal wall, during vaginal, oral, or anal sex. It can affect almost any body part, organs, or mucous membranes. So you can actually auto-inoculate yourself or someone else if you have it had on your hands or something like that. Or during fellatio, they can get inoculated in the eye. And I'm not even kidding you, when I was in PA school, this is during my last rotation. It was my preceptorship month. I decided, this is when, I don't know if you guys can travel outside of the States, but I just literally looked up in the phone book, picked out a PA out in California, because my girlfriend lived out in Long Beach. And he's like, oh yeah, I'll take you as a student. I'm like, yes. So I go out there. I have no idea anything about Long Beach, where it's located, and I guess this clinic is actually an inner city clinic. I had no idea. I didn't know the bad side of Long Beach versus the good side of Long Beach. All I know is my friend Gina dropped me off there every single day, and she didn't tell me until after, years later, that I was in the ghetto of Long Beach. But anyway, the first time I ever saw gonorrhea in a patient, I can't remember, it was the patient or one of her friends asked me, can you get gonorrhea in the eye if you're performing oral sex on somebody? I'm like, yes, you can. She didn't believe me. She didn't think you could, but you actually can. It's a mucosal membrane, so you get squirted in the eye, you can get gonorrhea. Just telling y'all right now. Okay, so again, it's often accompanied with chlamydia, so GC and chlamydia always kind of goes together. And again, same thing here, it's very contagious, easily acquired. This is a little higher, so women with a single encounter with an infected partner can lead up to 50 to 70% of the time to get infected. So ladies and gentlemen, know your partners. Here again, nice little map of Oklahoma. Look at that. We're even worse than gonorrhea. We're in the dark blue now. We're just not in the light blue. So it's greater than 181 per 100,000. So, and with chlamydia, I think last year the total cases were like 42,000 in the year 2016. So that's
the cities of Norman and Stillwater.
Remember those douchey guys I was telling you about at the fraternity house? I'm telling you. I'm going to email this chart to my niece. Okay, and same with gonorrhea, most of the time the females are asymptomatic. They can, again, develop urethritis, cervicitis, so you see a little bit of a same kind of symptoms, right? Well, with the gonorrhea, they're going to be more purulent discharge. It's not just going to be that nice, thin, white discharge. It's going to be more of a yellow, a little thicker, green-colored discharge. They can also have dysuria and dyspareunia, which, do you guys know that term? So it's painful intercourse, okay? And then abdominal pain, again, usually they complain of as if they've developed PID most of the time. So again, this too can progress to PID, and you can have it intermittent vaginal bleeding or intramenstrual vaginal bleeding. So see, the gonorrhea one looks a little bit worse. The cervicitis is a lot more inflamed. The red, that transformation zone is a little bit more inflamed, a little bit redder, and it's just thicker. Although the other picture of the cervicitis of chlamydia, it's more, I don't know, you can tell it's still a little bit thinner than that thick cervicitis. Okay, in males, most of the time, so the men, they will come in complaining of overt urethritis. So at least they get symptomatic for this one. So they may complain that they just have pain when they urinate, or a lot of times they may say not really at the beginning, or they may say they have burning at the end of urination. But they will also have a mucopurulent discharge. And sometimes they also will note that if they let it go for a while, because men aren't going to come in right off the bat. They'll wait till it gets real bad, and then they may say they have bleeding as well. And that's just due to that chronic inflammation or increased inflammation. And again, with gonorrhea, they can develop the acute epididymitis, which is the unilateral testicular swelling and pain. They can develop prostatitis and cystitis as well. So this is kind of, see how the discharge in the male is a little bit thicker, that thick, purulent discharge, in the female as well. Sorry, I promise I'm not trying to torture you with this. And then this one is of epididymitis. So usually men's testicles are not that large. They shouldn't be. And I was telling Professor Rourke why I thought this picture was kind of funny, is I remember in PA school, we were taught, how do you relieve symptoms of epididymitis? It'd be scrotal elevation. So we put it under a pillow, and I was like, this picture actually looks like it's under a pillow. So remember, that's just something. Now, these are symptoms that they could have if they get gonorrhea in other places, like in the rectum from anal sex, or pharyngeal if they are doing any fellatio or cunnilingus, and then in the eyes, like we talked about. So you can get them anywhere you have a mucosal membrane, you can get gonorrhea. And so y'all can figure that out. Oh yeah, there's the accidental spread by fingers too. Sometimes if you don't wash your hands properly after having sex and you can touch your eyes, you can also pass it that way. Oh, the poor baby.
Creeped out by what's holding time.
I know. So that's gonorrhea's eye. And then down there, so it's kind of hard to tell the difference between, you know, strep pharyngitis and gonococcal pharyngitis until you culture it. And how do you diagnose this gonorrhea? Culture it from a swab from the site of infection. And then you can go ahead and empirically treat them if you think that, if obviously if your partner was recently diagnosed, you would treat them as an infection from gonorrhea. But a lot of times, like I said, in clinics, most clinics, you can do a urine PCR. But again, you won't get results for a while, but you can go ahead and empirically treat them. So see, this is like gonorrhea. Rocephin, or ceftriaxone is the generic name. 250 milligram IM plus azithromycin, 1 gram. So azithromycin shows up somewhere, but then don't forget to add rocephin in gonorrhea. Because I have found that there's a lot of resistance in gonorrhea treatment, especially with the fluoroquinolones. But these are the alternative treatments. If for some reason you don't have rocephin in your clinic, you can give them a prescription for a PO medication. And then again, if they have epididymitis, PID, or disseminated gonococcal infection, which we're going to talk about next, you can give them symptomatic relief, like ibuprofen, pain relief, things like that, scrotal elevation. And then untreated, it can lead to accessory gland inflammation like that Bartholin's or the schemes. I think I may put that in the wrong part. But then PID as well. And again, you can also have that Fitzhugh-Curtis syndrome. Now again, the test to cure is not recommended with the CDC if they've had the ceftriaxone plus azithromycin. Now if you had to use some other alternate treatment, then I would go ahead and test them 1 week after treatment, because it may not cure it, because the higher rate of cure is with the rocephin. And again, gonorrhea is reportable, so you must report it to the health department. Okay. And disseminated gonorrhea infection. So basically this is gonorrhea that's come through the lymph system and it starts spreading. And so these people, you can develop arthritis, tendinitis, and dermatitis. And they can also have fever. So the skin changes, they'll get these maculopapular lesions. It can be on their palms, their soles, their arms, their legs. You can develop abscesses from it when they get infected. And then the joints will have polyarthralgia, so pain, tenderness, swelling of their joints. And then purulent arthritis, so it looks really hot, really red, really swollen. So again, there's other differentials that you could think about when you're thinking of this, when you see someone with this. And with the purulent arthritis, the knee is the most common site. Look at that joint, that ankle joint, they're horrible looking. And so there's little spots you get in your hands. And then it can also affect your central nervous system. So you can get meningeal symptoms, little altered mental status, and it can also affect your heart. So you can develop murmurs, tachycardia, and then endocarditis. What was the most common cause of endocarditis? Huh? The bacteria that causes endocarditis. Strep viridans. board question. Usually. I say that, but I haven't had to research in almost 6 years, and to do it next year, I'm not excited about that. So when you guys won't be, I was like, oh, I'll be taking it when you guys have to take it. It's actually the next year's, the class that I'll be taking it with him. All right, so treatment for disseminated gonococcal infection is ceftriaxone, IM every 24 hours, plus, again, azithromycin for 7 days. So if they end up, you have to switch them, you can switch them to oral medication within 24 to 48 hours, depending upon the susceptibility. So a lot of times you'll do culture and sensitivities, and they'll tell you if they are susceptible to PO. If not, you'll have to send them home with a PICC line or something like that to give them their IV. All right. So again, the special points are about the same. Anyone who comes in with genital symptoms, the first thing you're going to test for is GC and chlamydia, because it's the most common. And then any sexually active person can be infected. And then, like I said earlier, you should screen. So if you get positive for it, but your partner's not having any symptoms, you should still go have them get tested. And then yearly screening for sexually active women under the age of 25. And then people who test positive for gonorrhea should be tested for other STDs. But a lot of times the young folks that come in, they'll want the gamut of STD screening. But if for some reason you only think that they only came in complaining of gonorrhea and it comes back positive, test them for the rest. Oops. And this is just just a repeat of the testing that you can do. And something called the ELISA, which I don't really use for gonorrhea and chlamydia, so mainly it's the first two, the nucleic acid amplification tests and the cultures. Any questions so far? Okay. A lot of information about 2 little bacteria, right? Unfortunately, that's STDs for you. Because the only bad thing is I have to tell you about signs and symptoms both men and women, and then during pregnancy, so there's a lot of things you have to consider with STDs. So the next one is trichomonas. The girl that I was talking about, well actually it wasn't her, it was another lady I did a pap smear on out in Long Beach. She had gonorrhea and trichomonas. So when I did her pelvic exam, there was a lot of really purulent discharge. Okay, trichomonas is caused by T. vaginalis. It's an oval-shaped, flagellated protozoa. So these look like little footballs, swimming footballs. And again, you can have it in the vagina, the cervix, the urethra, bladder, and any of the other Bartholin glands, Skene glands. And in men, it's usually at the usually located in the anterior urethra and the prostate. Incubation is days to weeks. So see, do they look like football? Kind of. Yeah. And see the little flagella. Okay, signs and symptoms. So again, these people too can be asymptomatic. They'll get discharge, dysuria, burning, itching in men. But women, so this one is the more purulent discharge. They get copious, frothy, usually green discharge. So this lady that I had only had the green discharge as well as the thicker gonorrhea discharge. I mean, when I put the speculum, it was just like running out towards mine. So they can have dysuria, vaginal irritation, vulvar edema, just from all the swelling irritation. And then this is another board question, or usually a test question, is strawberry cervix. Which I couldn't see the strawberry cervix because there's too much discharge.
You need to wash it first.
Yeah. Strawberry cervix. You may never eat a strawberry again. So the other side on the right is like just, see, so she had all that discharge like that, and you could, so that picture you could barely see a little bit of that strawberry cervix. But that's all the frothy. See how it's frothy and bubbly? So if you guys ever do a pap smear and you see frothy discharge like that, it is trichomonas interpreted epididymitis.
Always on the boards, it's frothy.
Yeah,
I don't
frothy.
know why they love that word.
Yeah. So now when you go get your cappuccino, if
That's
that's
it,
what you
ruined
want
coffee.
on your coffee, you're like, no, I'm just going to run.
Yeah, I've had a strawberry.
More foam, some more
Frothy
frothy.
strawberry.
Okay. And how do you diagnose it? Same way you diagnose the other ones. You can do a wet mount prep. So when you prepare it, put it on the slide. You can see the little guys moving around on their slides. Again, I'm not very good at microscopy. You know,
Is that with a naked eye or under?
under the microscope. So you can culture it, do the amplification tests, and then something called a DNA probe as well, which I've never used a DNA probe. You see, look at those little, they just float around with their little arms. There's the frothy discharge again.
They're kind of cute.
Oh, Keela, did you say they were cute? Are you
Look at this video. He's kind of cute. He's just like, he's like swimming.
He's swimming?
Yeah.
Oh. Just no, it's swimming inside you. How about that?
Maybe that's what makes them frog.
Yeah, this
Flagella.
Kids get scared.
Okay. And trichomonas is metronidazole. It's 2 grams PO in a single dose. If anybody ever taken metronidazole before, you know how it has a horrible metallic taste, and so make sure you tell your patients that. It has a horrible metallic taste, and for them to not drink alcohol while taking this medication, unless they want to have a sulfa reaction. You can also develop a serotonin syndrome, I think, serotonin-like syndrome with... What you guys stuff? Come on.
Yep, see them.
Nailed it.
Diverticulitis.
These all pulls together.
So again, someone who comes up positive for trichomonas, you want to check them for gonorrhea, chlamydia, HIV, all of the... Because usually if they have one of these bad ones, they probably have one or more of the other ones. Okay. And again, with trichomonas, complication is PID. And in pregnant women, if they have it, they can have early preterm delivery, or a baby who has low birth weight. And the use of metronidazole in the first trimester is typically avoided because it can be at high risk for the baby. And because of the high risk of reinfection, you recommended to recheck after 3 months of treatment, regardless if their partners were treated. Which is kind of interesting. So it says data was insufficient on retesting men. And then up to 53% of women with HIV are also infected with trichomonas. So again, if you see somebody for the first time in an HIV clinic, you also want to check to make sure they don't have trichomonas as well. Y'all want to take a break real quick? Okay, go take a break and we'll come back and finish. Well, try to finish.